Greetings, dear learners. In the last class, we covered different aspects of ethyl alcohol poisoning. Today, we shall learn methyl alcohol and ethylene glycol. Methyl alcohol, also referred to as methanol, wood alcohol, or wood naphtha, or the wood spirit, is a clear, volatile liquid with an odor similar to that of the ethyl alcohol and a sharp taste when ingested. Methanol is produced through the destructive distillation of the woods, leaving behind activated charcoal. Methanol has a very rich history. Methanol was the part of the embalming fluid in the ancient Egypt. In 1661, Robert Boyle isolated it from the distillation of boxwood and dubbing it as spirit of the boxes. Industrial scale production commenced from the 1923 primarily for the synthesis of other chemicals. In India, methanol is often added as an adulterant to ethanol, leading to numerous poisoning, especially from the consumption of adulterated alcohol that is often referred to as Hooch tragedy. Common household products that contains the methanol are the antifreeze, paint removers, carburetor cleaners, and the varnish, serving as a solvent in these applications. Mineralized methylated spirit consists of 90% by volume ethyl alcohol, 9.5% wood naphtha, and the 0.5% crude pyridine. Toxicokinetics of the methanol is that it is metabolized to the formaldehyde, that is 33 times more toxic than the methanol, and then that formaldehyde is metabolized to the formic acid, that is 6 times more toxic than the methanol. So the metabolites of methanol are more toxic than the methanol itself, and the maximum side effect and the complications are produced because of the metabolites of the methanol. High concentration is found in the vitreous and the optic nerve. It is excreted chiefly from the lungs, that is around 80%, and about 5% is excreted unchanged in the urine. The mechanism of action of methanol is that it inhibits the cytochrome oxidase complex of the mitochondrial respiratory enzymes. Toxicity results from accumulation of two of its metabolites, that is formaldehyde and formic acid, the latter being the main culprit. Formic acid is converted into the CO2 and the hydrogen by the enzyme tetrahydrofluoride 10-formyl tetrahydrofluoride dehydrogenase. Severe non-diabetic anion gap acidosis in unconscious person is suggestive of methyl alcohol poisoning. So a person who is non-diabetic and has anion gap acidosis presents unconsciously is very suggestive of methanol poisoning. Fatal dose for methanol is 70 to 100 ml and fatal period is 24 to 36 hours. Then the various clinical features that are seen in the methanol poisoning. Methyl alcohol induces symptoms resembling the drunkenness similar to the ethyl alcohol, but the inebriation effect is less pronounced as compared to the ethanol, while its impact on the central nervous system is more intense and prolonged. Gastrointestinal symptoms that are produced due to the methanol poisoning often manifest as nausea, vomiting, pancreatitis, and severe abdominal pain resembling severe cramps. It is said that suspect the methanol poisoning in individuals experiencing the abdominal pain and visual disturbances following the alcohol consumption. Then on the central nervous system, it causes the headache, neck stiffness, vertigo, confusion, delirium, and the coma, although they are less prominent than those caused by the ethanol. Ocular effect. The eyes are primarily affected by the formic acid, leading to the various complications that includes the visual disturbances including photophobia and the blurred vision. It may progress to complete and permanent blindness. Formic acid inhibits the cytochrome oxidase in the optic nerve, resulting in optic neuritis and the atrophy. As little as 15 milliliter of methanol can cause the blindness. Retinal edema and the hyperemia of the optic discs are seen. Scotoma, that is the central and the peripheral scotoma, are seen in the patients, and the nystagmus is also present. Due to inhibition of the cytochrome oxidase by the formic acid, Optic neuritis and the atrophy ensues that may progress to the complete blindness. Pupils become dilated and fixed in the later stages. Then it causes the metabolic acidosis, that is high anion gap acidosis. Accumulation of acetic acid and the formic acid results in the high anion gap metabolic acidosis, leading to the widespread degenerative changes in the internal organs and the retina. Death may occur due to the metabolic acidosis itself. Acute tubular necrosis are seen in the renal parenchyma. Urine exhibits strong acidity and may contain the acetone and the traces of albumin. Other features like the muscular weakness, dyspnea, hypotension, tachycardia, and coma may last for 2 to 3 days. Then here you may see in the picture that alcohol dehydrogenase causes the metabolism of ethylene glycol to glycoaldehyde, methanol to formaldehyde, then the propylene glycol to lactaldehyde, diethylene glycol to the 2-hydroxyacetyldehyde, and the isopropanol to the acetone. They are further metabolized by the aldehyde dehydrogenase into the glycolate, formate, lactate, 2-hydroxyacetate, and then again the ethylene glycol is metabolized to glycolate and that to the oxalates. Then we will see in the ethylene glycol these oxalates crystals are seen as the metabolites, and then in the case of the diethylene glycol, diglycolate H is produced. Also we can see in the part B of the chart, as the time increases, osmolar gap decreases whereas the anion gap increases. That means initially when the metabolites are not produced at the initial stage of the intoxication with different types of alcohol, osmolar gap is high whereas the anion gap is low. Slowly as the metabolites are formed like the formic acid and formaldehyde, anion gap acidosis increases, there is the anion gap formation whereas the osmolar gap decreases. So methanol that is metabolized to the formic acid, ethylene glycol that is metabolized to oxalic and glycolic acid, diethylene glycol to 2-hydroxyethoxyacetic acid and glycolic acid, and propylene glycol to the D-lactic and the D-lactic acid, and propylene glycol to the D-lactic and L-lactic acid. An increased osmolar gap is prominent early owing to the accumulation of unionized alcohols. As the metabolism proceeds, the osmolar gap declines with the formation of ionized metabolites. Conversely, serum anion gap is lowest before the alcohol is metabolized and increases with the formation of the ionized metabolites. In this way, high anion gap metabolic acidosis is presented in case of methanol poisoning. Then for making the diagnosis of the methanol poisoning, important findings are the high ion gap metabolic acidosis, then elevated osmolar gap as we talked in the initial stage, and elevated osmolar gap greater than 10 milliosmol per kg of the water suggests the presence of toxic alcohol. Osmolar gap of 25 or more can be considered the need for the therapeutic interventions for the management of methanol poisoning. Then the features that is seen is the hypophosphatemia, elevated creatinine phosphokinase level, elevated amylase level. These all may be measured through the blood testing. Then the blood methanol level is the important point. The level more than 50 mg per 100 ml indicates the serious poisoning. Also, a detectable serum formic acid level may be consistent with the methanol poisoning as methanol is metabolized to formic acid. CT scan and MRI may show the symmetrical areas of necrosis in the putamen of the brain. CT scan and MRI are of good value as they will show the symmetrically areas of necrosis in the putamen of the brain and are the classical findings seen in cases with the acute lethal methanol toxicity. However, these findings are also present in other conditions and so they are not pathognomic of the methanol poisoning. As you can see here in the picture of the MRI of the brain, the putamen necrosis is bilateral, that is in the presentation. So this is suggestive of the methanol poisoning. Fundoscopic changes are notable within only a few hours after the methanol ingestion and range from the retinal edema in the perimacular region to the entire fundus. optic disc edema and the hyperemia are observed within 48 hours. You can see here in the picture hyperemia, optic disc edema and the retinal edema. All the findings may be seen on the fundoscopy. That is the characteristic of the methanol intoxication. Then the electroretinography and the visual evoked responses that show the characteristic findings that include the loss of retinal sensitivity, scotomata on the visual evoked response testing, although latencies are usually normal finding. Then the optic coherence tomography may also be done. It has been found to be very useful for evaluating the severity of the retinal edema and detecting the swelling of the nerve fiber in patients with the methanol poisoning. So, in this way, diagnosis of the methanol intoxication is confirmed. Then, for the management of the methanol poisoning, methanol concentration of 25 mg per deciliter is the threshold for starting the treatment. An ingestion of even 0.25 milliliter per kg of 100% methanol would theoretically, assuming the 100% absorption, results in the toxic methanol concentration. For its management, stomach should be washed with the sodium bicarbonate solution. Activated charcoal is not of much value as it doesn't absorb the specific amount of the methanol. Then the best antidotal therapy for the methanol poisoning is ethanol itself. Ethanol is the specific antidote since it preferentially competes for the same enzyme, that is alcohol dehydrogenase, and prevents the metabolism of methanol, which is then excreted unchanged in the urine. So, ethanol competes for the same receptor on the alcohol dehydrogenase and it has the more affinity and it binds with the alcohol dehydrogenase. So, no alcohol dehydrogenase is available to metabolize the methanol. So, the methanol remains in the blood and that gets excreted in the urine. However, the ethanol metabolites that produces not that much toxic effect will not cause the much botheration for the patient and the patient may be prevented from the further complication of the methanol toxicity. So, the methanol poisoning is one of the few cases where for the treatment of a poison, another poison is given. Mode of administration of ethanol is that 10% ethanol is given at a dose of 10 ml per kg. It is administered over the period of 30 minutes followed by 1.5 ml per kg per hour so as to produce and maintain a blood ethanol level of 100 mg per 100 ml. Blood ethanol level should be maintained at 100 to 130 mg%. In a child, however, infusion rate should be adjusted to obtain an ethanol level not more than 100 mg per 100 ml. Alternatively, 1 mg per kg of the 95% ethanol in the fruit juices can be given orally over the 30 minutes. For maintenance, administer 0.17 to 0.28 milliliter per kg per hour as 50% ethanol in the fruit juices. If neither of these is practicable, give 125 ml of the distilled alcoholic beverages like the gin, vodka, whiskey or the rum orally, diluted in the glucose solution or the juice and repeat as required very cautiously. Ethanol therapy shall be continued until the methanol blood concentration is less than 10 mg per 100 ml and the format blood concentration is less than 1.2 mg per 100 ml. Also, the methanol induced acidosis, serum amylase, osmolar gap has been corrected. Then only we have to stop giving the ethanol for the treatment. Also, in place of the ethanol, 4-methyl pyrazole, that is fomepizole, that doesn't cause the CNS depression may be given in place of ethanol for the treatment of the methanol poisoning, as this also inhibits the alcohol dehydrogenase so that its metabolism is prohibited. The dose for the 4-methyl pyrazole is that up to 20 mg per kg of 4-methyl pyrazole in divided doses can be given without any demonstrable toxicity. The usual loading dose for the 4-methyl pyrazole is the 15 mg per kg followed by the doses of 10 mg per kg every 12 hours for the 4 doses, then 15 mg per kg every 12 hours thereafter until the methanol concentrations are undetectable or have been reduced below the 20 mg per deciliter and the patient is asymptomatic with normal pH. Administer a dosage as slow intravenous infusion over the 30 minutes. Then the sodium bicarbonate IV is given in the adult in the dose of 1 to 2 milliequivalent per kg and in the child 1 to 2 milliequivalent per kg, titrated to correct the arterial pH. Folinic acid is also advised. Folinic acid IV is also advised in the management of the methanol poisoning. It is given in the dose of 1 to 2 milligram per kg 6 hourly. It hastens the elimination of formic acid, folinic acid, that is 5-formyl tetrahydrofolinic acid, 5-FTHF, or leucovorin, or the cytrovonum factor is the biologically active form of the folic acid, that is the petroyl glutamic acid, which is an essential water-soluble vitamin. For convulsions, attempt initial control with the benzodiazepines, diazepam or the lorazepam, and the seizures persist, then administer the phenobarbital. Hemodialysis is effective in the removing methanol, formaldehyde, and the formic acid. While ethanol treatment is also effective, it is extremely difficult to maintain therapeutic ethanol level for the long period of time. Hemodialysis is strongly recommended in the patients with acidosis or the serum methanol level greater than 25 to 30 mg per 100 ml. Dialysis once begin shall continue until all the features of the poisoning are resolved and the blood methanol concentration comes to the normal level. Particularly, methanol level decreases below the 20 mg per deciliter. Hemoperfusion is seen to be not very effective in case of the methanol poisoning. Then, in case of death of the person, the cause of death could be the metabolic acidosis and other various complications associated with the methanol poisoning. On the autopsy, the findings include the cyanosis, prominent cyanosis, especially in the upper parts of the body, is observed. Liver and kidney show the toxic damage that is evident in the liver and the kidney. Lungs examination may reveal edema, emphysematous change, and the de-esquamatation of the alveolar epithelium. Evidence of retinal edema may be seen on the fundoscopy. Then the putamen necrosis that we show on the MRI or the CT scan, that also may be seen at the autopsy and on the microscopic examination. Here it is important that during the autopsy, it is crucial to preserve the viscera in the saturated salt solution, not in the rectified spirit, which is used for other alcohol intoxication. Additionally, preserving one cerebral hemisphere is advisable along with the routine viscera examination. In this way, diagnosis of methanol poisoning at the autopsy is made. Then Hooch tragedy is associated with the methanol poisoning. Hooch originates from the Hochino Indians of the Alaska, known for their potent whiskey. In general, it refers to the low quality alcohol made informally, lacking the safety standards and posing several health risks if incorrectly prepared. Two main methods of preparing this Hooch alcohol, that is the fermentation method and the maize-based method. In fermentation method, yeast and the fruit ferment in the water and the mixture is heated to collect the concentrated alcohol, risking dangerous impurities due to the lack of quality control. In the maize-based method, maize, sugar, water and the yeast ferment is used to produce the alcohol with the similar risk due to the absence of quality checks. Methanol poisoning cases often arise from the accidental consumption of methanol containing products by the individuals deprived of the ethanol or the intentional adulteration of ethanol, leading to the tragic liquor tragedy reported in the Indian newspapers regularly. In year 2011, West Bengal reported the Hooch tragedy that claimed more than 170 of deaths. In this way, the Hooch tragedy is the mass fatality that is occurring because of the drinking of some impurity containing the alcohols. These are all the important aspects with respect to the methyl alcohol poisoning. Then coming to the ethylene glycol poisoning. Ethylene glycol appears as a colorless thick liquid with no smell and a slightly sweetish taste. It is known as glycol due to its sweetness and can absorb twice its weight in the water at 100% humidity. It is commonly used as antifreeze substance. Over a quarter of ethylene glycol production is used in the antifreeze for the vehicle and aircraft engines. It is also found in the condensers and the heat exchangers. It is also used as a solvent, hydraulic black fluid, glycerine replacement, ethylene glycol substitute for the glycerine in the products like the paints, detergents, and the cosmetics. Chemical binding block. It is a key component in making polyester fibers, films, and the resins. Fatal dose of ethylene glycol is 70 to 100 ml, while the fatal period is about 3 days. Then the toxicokinetics and the metabolism involved with the ethylene glycol. As you can see here in the picture, methanol, ethanol, and ethylene glycol are all metabolized by the alcohol dehydrogenase. This enzyme is competed by the fomepizole that is used for the treatment of ethanol and the ethylene glycol and ethanol as well, and ethanol in case of poisoning with methanol and ethylene glycol. Then the methanol is metabolized to formaldehyde, and that formaldehyde is metabolized with the aldehyde dehydrogenase to the formic acid, and that formic acid is metabolized to CO2 and water, and it is again here inhibited with the help of the folinic acid. So in the treatment of the methanol poisoning, folinic acid is given. Then for the metabolism of ethanol, it is metabolized to acetaldehyde and then to the CO2 and water. Whereas the ethylene glycol is metabolized with the help of the alcohol dehydrogenase into the glycol aldehyde, that is metabolized to the glycolic acid, and that is metabolized to the oxalic acid, and that to the calcium oxalate. And in this way the metabolism of the ethylene glycol occurs. Ethylene glycol doesn't get absorbed through the skin and is not harmful to the inhale due to its low vapor pressure. It gets quickly absorbed in the gut. Once inside, alcohol dehydrogenase breaks it down into the glycoaldehyde, glycolic acid, and the alcoholic acid, which disrupts the various body processes including energy productions. Other byproducts of ethylene glycol include the glyoxylic acid, glyoxal, and the formic acid. The harmful effect of ethylene glycol on the central nervous system, metabolism, heart and the lungs and the kidney are mainly due to the buildup of the toxic metabolites of the ethylene glycol metabolism like the glycolic acid. These cause their effect through the acidosis, kidney swelling and the other problems. Initial symptoms in case of the ethyl glycol poisoning is resembling the alcohol intoxication that is caused by the unchanged or unmetabolized ethylene glycol. Then the clinical features seen in case of ethylene poisoning are seen in the 3 stages. Phase 1 is the CNS stage, phase 2 is the CVS stage, and the phase 3 is the renal stage. Phase 1 in the CNS stage, it lasts up to the 12 hours the post ingestion. The symptoms that are seen are the vomiting, inebriation, lethargy, nystagmus, ataxia, convulsions and the coma, facial paralysis, strabismus, ophthalmoplegia, papilledema, mydriasis, retinal injuries and the eye throat irritation may occur. Cranial nerve deficit may result in the dysarthria, dysphagia, facial weakness and isochoria, ataxia, facial dysplasia, hearing loss or absent gag reflexes. Then the phase 2, that is the cerebrovascular stage, it occurs between 12 to 24 hours post ingestion of ethylene glycol. The patient presents with the tachycardia, hypertension, sometimes hypotension also, tachypnea, congestive heart failure and the circulatory collapse. Severe metabolic acidosis with compensatory hyperventilation can develop with multiple organ failures in the significant poisoning. Tachypnea and the Kussmaul's respiration may be the first clinical signs of the developing metabolic acidosis, which if untreated can progress and become the life-threatening. Cardiogenic pulmonary edema may occur with the severe poisoning. Then the stage 3, that is the renal stage, it occurs between 24 to 72 hours post ingestion. Patients present with oliguria, flank pain, acute tubular necrosis and the renal failure. Urine contains the calcium oxalate or the hippurate crystals. Calcium oxalate crystals are found as the monohydrate, prism or the needle shaped, rhomboid shaped or the dihydrate, tent or envelope shaped crystals. That is the very characteristic of the ethylene glycol poisoning. Hematuria and the proteinuria are also common. Hypocalcemia can result in the manifestation of the tetany. The patients may progress to the adult respiratory distress syndrome, that is ARDS. Delayed and inadequately treated patients may develop cerebral edema, basal ganglia, and the thalamic lesions, herniations, and other features. Then for the diagnosis of ethylene glycol poisoning, again here also the high anion gap acidosis is seen. Ethylene glycol breaks down into the acids causing acidosis. A high acid level suggests the late presentation and significant breakdown of the ethylene glycol. Then the osmolar gap, we already talked. In the initial state, osmolar gap is high, whereas if the metabolites increases, ionic forms increases, so osmolar gap decreases. So this test estimates the ethylene glycol levels. A high gap indicates the poisoning, but it can decrease later as the body metabolizes the ethylene glycol. Then the calcium oxalates in the urine is another characteristic findings to make the diagnosis. These crystals, that is envelope shaped crystals, indicate the ethylene glycol intake and the poisoning. Then the CSF is the yellowish fluid with a more white cells that suggests the central nervous system involvement due to the ethylene glycol poisoning. Blood ethylene glycol levels should be checked considering time and the patient's condition to assess the severity of the poisoning. Then the glycolic acid test, that is done using HPLC and the gas chromatography, and detects the acid level, helping doctors to make the treatment decision for the ethylene glycol poisoning. Fluorescent urine. Another interesting finding in the ethylene glycol poisoning is the fluorescent urine. Antifreeze injections might cause the urine to fluoresce in the lamp, but it is not always a reliable indicator for the ethylene glycol poisoning. Then the management of the ethylene glycol poisoning. Promptly evaluate the patients as the patient arrived in the casualty or in your clinic. Conduct the serum electrolyte, blood urea nitrogen, creatinine, and the urine analysis test for all the injection cases. Those with the symptoms or acidosis should have the arterial blood gas analysis. If ethylene glycol concentration level is delayed, then assess the plasma osmolarity. Check blood ethanol if the ethanol injection is suspected. Initial tests include the CBC, electrolyte, magnesium, calcium, detection of the glycolic acid using HPLC and the gas chromatography. Then for the treatment, the main antidote is the IV ethanol and fomepizole. Ethanol is given in a similar way as given in the methanol poisoning. It is given in IV infusion or the orally with the orange juices. Then the ethanol maintenance dose is the 100 mg per 100 ml, and that is given and it shall be stopped until there is the recovery from the symptoms and the blood parameters are within the normal range. Then the fomepizole is given initial 15 mg per kg IV over the 30 minutes, then the 10 mg per kg every 12 hours. Administer IV bicarbonate for the control of the acidosis, thiamine, pyridoxine, and the 10% calcium gluconate IV given for the hypocalcemia. Consider hemodialysis in the severe cases, continuing with the ethanol and fomepizole during the dialysis. Early action and the close monitoring are the crucial for the effective management of the ethylene glycol poisoning. Early action and the close monitoring are the crucial for the effective management of the ethylene glycol poisoning. Then the cause of death in case of ethylene glycol poisoning is mainly the renal failure. On the post-mortem examination, cerebral edema, chemical meningoencephalitis, liver and the kidney damage, and importantly, oxalate crystals are seen in the brain, spinal cord and the kidney on the microscopic examination. As you can see here in the picture from the brain, here the envelope shaped crystal, that is the oxalate crystals, are seen in the patients. So in this way, the diagnosis of the ethylene glycol poisoning gets confirmed. Rest or features at the time of autopsy are not very the features in case of the ethylene glycol poisoning are not very specific, and as the clinical features are presented in the patients, similarly the presentation can be seen on the after death, and also the features of the alcohol ingestion may be seen in the case of ethylene glycol poisoning. This is all related to the ethylene glycol poisoning. Then the one case that we were left with was that a 30-year-old drowsy male was brought to the casualty. His pulse was 130 per minute, respiratory rate is 30 per minute. His lab reports are given below. That shows the arterial blood gas analysis, shows the metabolic acidosis. Total serum calcium is 6.8 milligram per deciliter, that is hypocalcemia. Blood urea is 100 milligram per deciliter, increased. Creatinine is increased 3.4 milligram per deciliter. And on the urine analysis, there is the calcium oxalate crystals. That is very characteristic of the ethylene glycol poisoning. And he showed improvement on the nasogastric aspiration and the administration of the sodium bicarbonate, calcium gluconate, and 4-methyl pyrazole. So definitely it is in the group of the alcohol intoxication. What substance did he likely most consumed? So this was asked in AIIMS PG exam. So here you can see the best answer is the ethylene glycol. The features, all the features of the ethylene glycol poisoning. So in this way questions may be asked in your exams. So this is all related to the alcohol. We shall meet with the another topic in the next class. Thank you.